the first thing to think about is your model of care. Many people start to build a multidisciplinary clinic through referral-based care, which I think is a good place to start because it lets you understand how much your patients really need a service. But if there is a service that patients are using and patients are liking it, I would strongly consider bringing it in, not just co-located in the same spot, but actually fully integrated into the practice with the same practice manager, with the same billing system, and with the same electronic health record. Because having all the same systems will really improve collaboration of care. And that's been demonstrated in a lot of mental health fields. And we're just starting to see that the same principles hold true in neurology. So I think that that's the first big thing. The second big thing is to understand any new individual provider, interdisciplinary provider, is not going to be able to see every single patient. So the question is, which patients do you refer? I think that the best model is to come up with a proactive strategy for referring patients. So maybe every single patient in the practice does have a behavioral headache education class that they all take. And there are some practices that do run on that model and find it to be very successful. Maybe every single new migraine patient does see a psychologist, but obviously we don't need people with headache secondary to an infection or all, we may not necessarily need every single person who comes to a headache center to see a psychologist, but maybe people with primary headache disorders that have evidence-based treatment, maybe they're the ones that need to go see a psychologist. And I think one of the mistakes a lot of people make is they say, well, if somebody has psychiatric illness, I'll send them to a psychologist. There are thousands of psychologists out there who are well-trained to treat psychiatric illnesses. When you get a super specialist headache psychologist into your practice, I think that it is an unfortunate waste of resource to primarily use them to manage mental health concerns because they're trained, of course, to treat mental health, but also to actually reduce headache frequency and headache severity, headache-related disability. So you should consider a referral strategy model that more broadly refers patients who have higher levels of disability than you might expect, or who have specific lifestyle goals that they could work on with a psychologist, or something broader than my patient is depressed, my patient is anxious, because although, of course, a headache psychologist can manage that alongside headache, there are also many, many, many other psychologists and other mental health workers out there who would be able to handle the psychiatric comorbidity piece. And what you're really getting out of a headache psychologist is the headache treatment piece.